delivering multimodal prehabilitation to reduce the risk of deconditioning in patients listed for total knee replacement (TKR) surgery during the COVID-19 pandemic, a pilot study. Around 9% of people aged over 65 years have frailty. This rises to between 10 to 46% in surgical preoperative patients. In surgical populations, frailty has been found to predict postoperative adverse events and poor clinical outcomes, and is associated with increased opioid use, which is also being linked to postoperative opioid dependence and hyperalgesia. To date, there is no clear evidence of a relationship between COVID-19 and osteoarthritis, OA. However, OA does share a multitude of comorbidities such as cardiovascular disease, inflammation, and diabetes with severe COVID-19 cases. Therefore, the government advised that vulnerable patients, including those with OA, should be shielding to avoid a community-acquired infection. This, coupled with COVID-19 pandemic having an impact on already long waiting times for planned total knee replacement surgery to an average of 6 to 12 months, puts these already vulnerable patients at further risk of adverse postoperative events and poor clinical outcomes. One approach to mitigate these effects is to provide a prehabilitative program to safely and sufficiently manage OA patients once listed for TKR surgery, which is further recommended by NICE 2020 Joint Replacement Guidelines to have pre-operative rehabilitation, which includes advice on exercises, lifestyle, including weight management, diet, and smoking cessation to maximize functional independence and quality of life before and after surgery. The overall aim was to design, implement, and evaluate a pilot digital multimodal rehabilitation program that will target physical function, psychological burden, improve quality of life, and impact lifestyle factors such as smoking cessation and optimize pain management, aiming to reduce opioid dependency. Secondly, it was to determine how the program could be robust such that it could be delivered both face-to-face and digitally to control for residual shielding measures. Patients completed a minimum of 8-week digital multimodal rehabilitation program, which included smoking cessation advice, opioid reduction advice, nutritional advice, cardiovascular exercises, and strength and balance training interventions. Measures were taken at baseline, 8 weeks, and 3 months postoperatively. Only 5 of the 18 participants completed the 8-week intervention and 3-month post-surgical review. This was because 10 participants were fast-tracked surgeries when surgeries reopened, so did not complete the 8-week intervention, and 3 were not medically fit for surgery. Of the 5 who completed the program, results showed they improved from pre to post intervention, but only gait velocity was significantly different from baseline. Only 1 participant smoked, who gave up smoking prior to surgery and continued smoking cessation at 3 months postoperatively. Patients' weight did not change significantly from pre to post dietary advice, and all 5 participants were invited to a focus group to further understand the acceptability of the 8-week digital intervention to aid designing the future program for patients waiting for TKR surgery. Previous evidence has shown the PEAK program is an effective intervention for managing patients with knee arthritis. Patients' weight did not change from pre to post dietary advice, which is like previous research with patients with knee arthritis. Results show one deteriorated while waiting for their TKR surgery when they were shielding. Only 2 participants attended the focus group, which further provided information that all patients accepted the online multimodal rehabilitation program during peak COVID-19 pandemic, but recommended further tailoring of exercises in future cohorts. This pilot study will be used to inform further programs for patients waiting for TKR surgery. Limitations include participants with fast-tracked surgery, so only a small sample size was gathered. This increases the risk of type 2 errors and false negatives. The programme was completed in peak COVID-19, where there was a lot of unknown and anxiety about COVID-19, so it was challenging to complete this intervention.